Welcome, one and all. My name is Anna Lompriere, and I am a wayfinder. I work for the Cornwall Memory Cafe Network, supporting carers and people living with dementia to access services, make referrals, and really help them find a way to get more support. This is part of Disability Cornwall, and we've decided to create this podcast interviewing experts and people with lived experience on dementia to be able to share all sorts of interesting and informative and supportive information. So sit back and enjoy, and also share the podcast with your friends. It's relaxed and inclusive and welcoming, and thank you for listening. Welcome everybody to our Dementia Toolkit video series, a one-stop shop answering all your questions on everything dementia related. Simple educational advice from people with lived experience and professionals in their field. We aim to provide support that's personalised to help you on your dementia journey. We are here today, Anna Lompriere, the podcast host, supporting people that are living with dementia and their carers to access all sorts of information. I work with Disability Cornwall, and it is my total honour today. Thank you so much for your time, Simon. I have here today Simon Vann Jones, who is a consultant for old age geriatric people in Cornwall. He's the lead psychiatrist in Liskeard for the NHS, and today we are going to pick his magnificent brain about all things research, talking to you about medication, and busting some myths potentially. If you're listening and you're looking after somebody that is living with dementia, what are some of the best things that you can do to support that person to support their brain? So thank you so much for your time, Simon. And can I just ask, before we begin with all that you might introduce yourself a little bit further and tell me as well, or tell us how you got into this work and what your love of this work is.
Hi, Anna. Hi, everyone. Thank you very much. That's a very generous introduction. So I hope I can live up to it. So I am a consultant psychiatrist, as you say, in older people's mental health. Probably because I had a great relationship with my grandparents, and my grandparents had dementia. So I suspect that's probably the reason why this area appealed to me. And I've always been interested in dementia research as a result of particularly my grandmother's memory problems. And I've been involved from in my early days as a junior doctor. I got involved as an academic foundation doctor. So right from the very beginning, I had time involved in research and always dementia research. And then my career took me down to Oxford, where I was a clinical fellow, academic clinical fellow, doing more research in dementia. Although that was in demented fruit flies, but there is a link to people there. And then subsequently,
Wow.
I've come down to it was very interesting, but I won't bore. Interesting to me, at least. I won't bore you with that now. And then I came down to Cornwall to take on a registrar post, and then now a consultant post. But my latest research role is I'm NIHR, the National Institute of Healthcare Research Lead for dementia in the Southwest. That's the government's health charity for research, and so I'm the dementia lead for that. So basically my job alongside my clinical work is to really be evangelical about research opportunities, and to try and get our patients access, as I see it. My role is to try and get our patients access to the latest trials in dementia. So that's me.
Thank you. And it's fascinating. I interviewed quite a few people, and so, very qualified people. And so much of the time people will say they're inspired because of a loved one that has had that experience of living with dementia. So, it's interesting that. So I'm going to start anyway. Tell us then, what are the latest treatments? What, some people I've been to a few conferences and things saying that the drugs don't work And tell us from your expertise about that, what you
Uh,
feel.
okay, yeah. So some people do say that. I think they're wrong because I think it's very difficult to do studies in dementia because people, our participants, is a progressive disease, and keeping participants in a trial, recruiting in the first place is challenging, and then keeping people with a often rapidly progressing disease in a trial can be challenging. So dropout
Right.
rates are often pretty high, and that can make interpreting results, meaningful results, quite difficult. However, we do have a trial. So there's two drugs that we have at the moment. So
Okay.
we're thinking about drugs. There are non-pharmacological, lots of great research that doesn't involve medication, which we may get on to talk about. But in terms of medication, there are two drugs that are available, or two classes of drugs for Alzheimer's dementia. And
Okay.
those drugs have a role in other forms of dementia too. It's probably helpful to start by saying, as your listeners probably know, dementia is the umbrella term. Underneath that umbrella are different types of dementia. So, with diabetes, you've got type 1 and type 2. They're both diabetes, but they're different. Same in dementia. Dementia is the umbrella term. The main form, the type 2 diabetes, if you like, is Alzheimer's dementia. So about 7 out of
Right.
10 people have Alzheimer's. And then of the remaining 3 out of 10 who have dementia, it will be things like vascular dementia, so post-stroke or lots of mini strokes adding up to dementia, Lewy body, Parkinson's, frontotemporal dementias. There are lots of different types under,
Yes.
that make up those last three people. But Alzheimer's is the one that I guess we use almost mistakenly, but almost interchangeably with the word dementia.
Yeah.
Where that's useful is Alzheimer's is the one that we have done the most research in, and that's the one that has the most robust evidence for knowing which drugs or which non-drug treatments can help.
Okay.
So forgive me if I use Alzheimer's and dementia interchangeably. I think what applies to Alzheimer's probably does apply to the others to a lesser or greater extent. But with
Okay.
Alzheimer's, there are two main medications that we use and have been around for about 2 decades. The first form is called a cholinesterase inhibitor, and the most common form, many people, listeners to this may be familiar with Donepezil. So that's the first line treatment. That also has a role. We know that helps in Parkinson's dementia, in Lewy body dementia, and it possibly helps a little bit in some forms of vascular dementia. Um, but in Alzheimer's, it definitely is a drug that makes a difference. And then there's a second drug that we can add on as people progress, because Alzheimer's, what it does is it improves some of the symptoms, improves your short-term memory. Sorry, Donepezil, sorry, improves some of the symptoms, improves your short-term memory, maintains your or reduces your likelihood to be admitted into an institution only by a little bit. Helps a little bit, doesn't help a lot, but a little bit can mean a lot.
Yeah.
In a rapidly progressing disease. So Donepezil helps, but it doesn't hold the disease at bay. It slows it
Okay.
down a little bit. It mainly helps the symptoms, but it doesn't hold things at bay. It's not a miracle. It doesn't fix the damage. So when things progress, then another drug called Memantine, which works in a very different way. It works by essentially sort of blocking the damage that dying brain cells, when they die, they cause damage to neighboring brain cells. So Memantine, the second drug, interferes with that a little bit. It's a bit of a neuroprotecting drug. Again,
Wow.
like Donepezil, it makes a difference. It does make a difference to most outcomes that matter, but only a little bit of a difference. But you're much better off. The research shows you're much better off being on both of those drugs than one of those drugs, and then you're much better off being on one of those drugs than none of those drugs. And
Okay.
and and I know that because there's a lovely study called the Domino study, which was a really robust study that looked at patients who were taking both of those drugs and took away one or other of them or both of them. And if you took away one, everyone got worse than those who stayed on two. And if you took away two, you got worse again. So it was a lovely
Wow.
graph, about 70 or 80 patients in each group, which is a good trial size for this group. It's about 300 patients in the study, and that to me is convincing enough that stay on
Yeah.
these medications, get on these medications. That's what NICE says, and stay on them. And I guess my plea to people listening is, if you know someone or you have dementia and it's Alzheimer's particularly, and you're not on both of these drugs, you should be thinking, why not? Do I need to be? Because I have
Yeah.
to say most people get the second drug, Memantine, probably way later than they should, because
Uh-huh.
it's from the moderate stages onwards, and the moderate stage is such a sort of vague term. So I think if you've been on the drug number one for a while, maybe
Yeah.
even a few months, you might want to be thinking, well, is it time for drug number two.
Okay.
Certainly, if people are experiencing anxiety or decline in their function, hallucinations, any of those really horrible symptoms that come hand in hand with Alzheimer's disease and the other dementias. So particularly Alzheimer's. So that's where we are. That's where we've been for about 20
Okay.
years. We have two medications that help.
And the sooner people are on the drugs, the better. Like getting it early, does that matter?
I mean, I would say yes, because it's all about slowing it down. And
Yeah.
that's what the evidence shows that these drugs do to it a little bit. Like I say, they're
Yeah.
not game changers, but if you stop it, you get back down to where you would be without them. So
Okay.
for that reason, you're thinking that the more you've got to preserve, the better. So the earlier, the better. But there is evidence for these drugs helping the whole way through. So whatever stage you're
Okay.
at, you should be thinking about whether you should be on one or both.
Amazing. So, my next question then is, what if we're talking about research and what's exciting and what's coming, and you were talking about also clinical studies in Cornwall. Can you talk a little bit about that?
Yeah, so today is the 23rd of October. I've got some sort of mixed news really. We've had exciting news this year, and that a drug has finally been approved in America and now by the European Medicines Agency for Alzheimer's disease for the first time in I think about 20 years. So that's really exciting news. The less exciting news today is that NICE aren't going to fund it there's a drug called lecanemab, and it works in a very different way to the ones we've got already. So lecanemab is looking to actually interfere in the disease course, to block the protein that causes, and actually to remove the protein, the excessive amount of protein that causes Alzheimer's disease. Again, forgive me for talking mainly about Alzheimer's disease, but that's where
Yeah.
most of the sort of exciting research is at the moment. So lecanemab was approved in, sorry, it's yes, lecanemab. There was another one, aducanumab, that was approved last year, and that's been a bit controversial. Lecanemab was a slightly less controversial one, and it was heralded with much excitement for a positive trial result last year, rapidly approved in the States where it's already being prescribed. The European agency, in fact, sorry, the European agency said they didn't approve it. The UK Medicines Agency did approve it, but it's gone to NICE, and NICE have said it's too expensive. The benefits
Gosh.
are the benefits are very modest, and the cost is prohibitive. So, and also the
Wow.
risk, about a third of people on this drug get brain swelling or brain bleeding. That's a massive risk, and so you have to have
Yes.
multiple follow-up MRI scans of your brain to make sure that's not happening to you. So it's a risky drug with very, unfortunately, mild benefits at best and incredibly expensive. So NICE have balanced it up and have said no.
Mm.
In a sense, it's wonderful that the research community had this shot in the arm that two drugs actually showed a promise in the disease for the first time in forever, and in
Wow.
massive trials, in phase 3 trials, hundreds of participants or more. But unfortunately, the benefits were only just a little bit. So that's where we are.
Yes.
What it has done, Anna, is it stimulated a lot more interest. Research money, pharma money was falling away from Alzheimer's disease because of so many negative trial results. That's starting to change. There's more excitement.
That's
So
good.
we're optimistic that new treatments are coming, and I can talk about a trial that we're running in Cornwall that might be of interest as well.
Yes. Yes. Tell us about the trial in Cornwall then.
So we're looking at I don't know how much I'm allowed to say because it's a commercial study, but it's an exciting, very exciting study that I've wanted to be involved with this particular drug, which I won't mention. It's very similar to a drug that's out there already that we think can be repurposed to help in probably all dementias, but certainly in Alzheimer's disease. And it's gone through a trial already, a phase 2 trial, which is a kind of smaller trial, basically checking does it work in. We know it's safe. Does it work in this patient population on a small level? And it showed that in people with early stage Alzheimer's disease, it did appear to make quite a difference. So it's now
Wow.
what we call a phase 3 study, which is a multi-center, bigger study, hundreds of patients all around the world. And we've been
Wow.
lucky. Yeah, we've been selected as a site in Cornwall. And so it's a drug that I think it works in a very different way to any other drug that's out there. It seems to be very safe. we're doing the trial to check whether it is safe, of course, and also to check whether it's effective, because often trials,
Amazing.
things look very positive at the phase 2 on a smaller group, but when you do it in a bigger group, you can, unfortunately, not many trials make it through phase 3 where we're
Right.
at. But
You're at phase 3.
but
And
the reason we're doing it is because we're excited.
do you need like, if people are listening, do you need more people to trial with you, or?
We are recruiting people with either pre-dementia Alzheimer's, so what we call prodromal Alzheimer's, because Alzheimer's disease is a process that begins many, many years, possibly even decades before you develop symptoms. So some people get diagnosed with a mild memory problem, but likely due to Alzheimer's disease. Those are the people we're kind of most interested in, or anyone who has a diagnosis of early Alzheimer's disease dementia. So those
Okay.
people, I would,
And
yeah,
how
please
would
get
they
in touch.
get in contact with you for that?
They would contact our research team at
Hmm.
Cornwall Foundation Trust, NHS. I could
No,
pick
that's
up their
okay, but
details,
I
but
can get the
if they
link
call our
off you.
switchboard, yeah, that would be
Yeah,
amazing. Yeah, that
we can put it in the
link
show
in the
notes.
text.
Okay, so then we've got 5 minutes
Okay.
to just talk about other things that people can do that have been had research that can as well as the medication, because you were saying at the beginning there are, people really are very interested in the medication, not so much interested in other things that are just as useful to slow the process down, or to take care of their brains. So any other suggestions for people, yeah, would be really welcome.
Yeah, sure. No, there's a couple of things that I recommend. One is exercise. So there is good evidence that exercise reduces or lowers your risk of developing dementia. And if you have dementia, it almost certainly slows the progression of your dementia if you exercise. There's a couple of reasons for that. It improves the blood flow to the brain, and it also stimulates something called brain-derived neurotrophic factor, which is like a stem cell factory in the brain. So it's a way of stimulating new brain cells, new connections in the brain. So it's kind of a magic bullet, really, exercise for any form of dementia, because of the way it works. It's
Wow.
also, yeah, so that's worth knowing. And so there's a couple of nice articles out recently. One was called 10,000 Steps a Day Keeps Dementia at Bay, and
Wow.
it was from this UK Biobank study. UK Biobank is this massive database of volunteers in the UK who it's about 500,000 people, I think, who give their genetic data. They're tested regularly. They have regular scans. It's an amazing repository of information, and they looked at and they do studies within that, and they showed that people who were walking 10,000 steps a day or 5,000 steps a day at a certain pace, if you walk 5,000 steps a day quickly, it's as effective. Their rate of or risk of dementia was much, much lower. So, and there's
Wow.
lots of studies of exercise. Sometimes studies of exercise can throw up surprising results, and actually not show a difference. But if you pull all the studies together and analyze them all as one, the benefits of exercise are absolutely there and clear and obvious. So that's whether you have it or you're at risk of it. I think exercise is probably the single most important thing you can do to modify your risk
Wow.
and modify your symptoms. So that I think that's a really positive message, and far
So
fewer side
positive.
effects than medication. So I would
That is amazing.
that's number one.
Thank you.
Yeah.
Number
So
one,
Google that 10,000 steps a day keeps dementia at bay.
I love
Um,
that.
and number two, so there is there's not so much evidence for this. There's smaller studies keeping your brain active. So again, we call it cognitive. So there's evidence for a form of therapy in Alzheimer's disease called cognitive stimulation therapy, and that has decent evidence for improving some of your symptoms. And really, that's about keeping the brain stimulated and various tasks, tests, games that promote connections in the
Wow.
brain. So that is again reasonably robust evidence for people who have the diagnosis. But again, people who don't have the diagnosis or at risk of dementia, the higher your reserve, the lower your risk of dementia. And there's some nice studies from the University of Southern California that took a small group of people and really challenged them with really difficult, they're in their 70s, challenged them with really difficult learning tasks, and made it really difficult. I think they gave them three things to learn. And if you were good at something, they didn't give you something like that. So if you were good at French, they didn't give you another language. They gave you a musical instrument, or some, you had to learn juggling. So they made it really difficult. And after 3 months, they tested the participants, and they de-aged their brain on testing by about 20 years. And apparently the participants were so taken by this that many of them carried on the experiment, carried on learning at least one more difficult thing daily, or regularly. And then after a 12-month follow-up, apparently they de-aged their brain by 50 years. So I mean,
That's
that's quite an amazing finding. But anecdotally, so
incredible.
I say this to all of my patients, the best thing you could do is try and learn something new, because that really does challenge you, and it's something you'd be motivated to do every single day. And I don't think I'm going to be giving anyone's details away here, but one of my patients really took that on board, and went away and learned. He always wanted to learn calculus. And so he went away and learned calculus, and he did increase his exercise. Actually, he was quite sedentary. And I saw him a year later for a research study I was doing, and he has Alzheimer's disease, and he hadn't progressed at all on his testing. And I
Wow.
said to him, I said, if I saw you like this a year ago, I might not have diagnosed you. And I think for me, he stands out as someone who really took that advice and ran with it. I mean, who wants to learn calculus? But he did, and he did a good job of it. And he's still keeping
It's
his
still
grey
going.
matter.
That's
Yeah, so
so
it is
inspiring.
use it or lose it. And
Yes.
the final thing, and this is based on one study, but I think it's a study worth knowing about. There's a study from Harvard in 2022, where they gave many people, I think the average age was around 70, a multivitamin every day, and half of them a dummy pill. There were thousands of people in the study, and then they performed cognitive testing on them at baseline, and then a year later. And the ones who were on the multivitamin were performing approximately 3 years better than the other group on
Wow.
testing. So it's like, again, it was like they sort of de-aged their brain a bit just from simple supplementation. So I think that is, for me, the study hasn't been replicated, and there were some perhaps issues with the analysis. But really, I thought, what, a multivitamin a day.
Yeah. Yeah.
So I recommend it to
That's amazing.
all of my patients, pretty much, particularly ones who are a bit low on some of their vitamins on blood testing.
Yeah.
But we don't test for all your vitamins and minerals, so I think that's worth knowing about. That was a study. It used the I don't this is no commercial interest. I have no conflicts of interest, rather, but it was a vitamin called Centrum Silver, and that has a really high dose of vitamin B12 in it, which we kn-
Ooh.
which we know is linked to shrinkage in the part of the brain that's affected by Alzheimer's disease. So
Wow.
Centrum Silver, it has a good dose of that in it. It might not have been the B12, it might have been, so any multivitamin
Yes.
may work, but I specifically recommend that one because it was the one that was used in the study. But the caveat being, it was one study, it was thousands of participants, and you could sort of interpret the results as maybe not being as dramatic as the press release, but actually, I think I would really recommend people take a
Yeah.
multivitamin, particularly one that's got B12 and vitamin D in it, because most people are a bit low in that,
Yeah.
and a good reason for that. More time indoors, and you don't absorb vitamin B12 so well as you get into your sixth, seventh, eighth decade. So I would
Amazing.
encourage people. It's a very low hanging fruit, that just take your daily multivitamin
Yes.
and
Thank
forget
you,
about it.
Simon.
But
This
okay,
is amazing. It's been really informative and so inspirational, and it's making me think, yeah, how simple is that to just get yourself a good quality vitamin, multivitamin, making sure you're getting your B12, learning new things, stretching your brain, and as well, speaking to your doctor about these medications if you're not on them, and making sure, because they are making a difference.
I've got one more thing to add, Anna, which is probably
Yeah.
actually the most important of all. So, alongside that paper, 10,000 steps a day keeps dementia at bay, there was another paper. It was a conversation a day keeps dementia at bay. And that was a wonderful study where they took people who were socially isolated, and just made contact with them 3 times a week. That was the sort of minimal input. And even people who had that slight increase in social interaction, their cognition dipped. I can't remember if those people actually had dementia or were at risk of, but they certainly had a measurable cognitive impairment the follow-up had not declined or had got slightly better than the
That's
group
so
that didn't have that.
lovely.
And so I often say to people, actually, the best form of cognitive stimulation is seeing your friends and family and keeping up your social life. And I think as you develop memory problems, you can lose confidence and you can withdraw from that. And particularly, memory
Yes.
problems often go hand in hand with finding the right word and speaking problems. And actually, the worst thing you could do is withdraw. And I think people are often very self-conscious about that in a way that they wouldn't be if it was a friend who had those problems. Wouldn't think anything of it. So
No.
yeah, so often I'm encouraging people to just keep up that social, like keep seeing your friends, keep getting out there. And that might
Yes.
be, well, I do think it's just as important as anything else, and it's way more enjoyable than exercise and taking drugs. So, that would be my final thing. Those sort of
That's
four things, really.
amazing. It seems so obvious as well, isn't it? It's keeping those conversations and your brain alive and everything. Otherwise, you can just feel so socially isolated, just watching the television and shutting down.
Yes, yes. And
Yeah.
to bore you, there are studies. There are studies that show that people that watch more than 3.5 hours of telly a day, their dementia progresses much more
Faster.
quickly. And you think it's probably not because
Wow.
telly's bad for you. It's just as you're saying, it's replacing the good things. And so
Yes.
passively watching TV is not the same as having a conversation. And
Yeah.
so that's a problem. Too much good TV.
Yeah, too much. Oh, that's amazing. Thank you so much, Simon. It's been really, really
Pleasure.
interesting. Thank you.
Lovely to meet you.
And you.
This video was produced by Discover Voices, part of Disability Cornwall and Isles of Scilly. To check out all of our content, simply search Discover Voices on YouTube.